case over here. Not a very big deal once again. Class 3, see? Class 3. She has a little bit of a mental problem and blah blah blah. And her main concern was the anterior traumatic occlusion between upper and lower incisors. She says every time she chews, bites something, the upper and lower incisors, they ache. I mean, I feel pain just because they are hitting each other. Then maybe we'll have to think about raising the bite or something here and there. And then if you raise the bite, the back side, and the molar will be intruded just because the isolated bite raising or something. So something has to be done. This is a mild class 3 relationship. Have a look at the molar, premolar segment. And then again, maybe because of the tongue pressure, we have a lot of this tapered arch, especially in the mandible. Maybe because of tongue pressure. Maybe I can align the teeth with a lingual fixed appliance, but it's not easy to correct the arch form with a single line of wire. If she wants invisible treatment, for example. Do you understand? Basically, she wants invisible treatment. So we have two choices, aligner or lingual fixed. This tapered arch has to be corrected to be able to create the space for the lower incisor. Just like that. Now, let's have a look at the cephalogram. Proclination of the lower incisor, which is not a big deal, because tipping is always easy. And now, it's time for me to introduce the universal attachment. I was very much annoyed by the diversity of the attachment. And here you have only one single form of attachment that are attached on the tooth even before the clinching. That's what is important. We attach the attachment even before we send the file to the align tech or Seraphim. And in the clean check, it's already attached just like that. What does it look like? It's a teardrop shape, and it's patented. Let me tell you, you're not supposed to copy it. It's patented, and it has a uniform, just like that. Then, the clean check is almost the same. What did I say? I told you, aligner has a weakness in the transverse correction, but in this particular case, we basically need to align the lower incisor, and also we have to correct the arch form as much. Wow, clean check is always beautiful. Clean check is always beautiful. If you are wondering whether the teeth will move exactly the way it shows. In the upper arch, nothing much. Just a little bit of rotation of the upper, not a big deal. You can do it even without any attachment, no problem. But in the lower arch, we need to correct the arch form from taper to a little bit broad. We also have to disalize the molar just like that. Is that going to be possible? Yes, sir. We'll give it a try. What did I do? We use a universal attachment here and there, just like that, from the beginning. The procedure is you put an attachment and you scan the mouth. And then send all the files to the laboratory, and they will make a clean check with the attachment on, and then you start to use the number 0 aligner from the very beginning. Just like that. Universal attachment is attached to the... Now, this was again in the beginning. We are still in the process of developing the clinical protocol, and as of now, my proposal is to attach the attachment from 3 to 7, regardless of the case. From 3 to 7 in the maxilla. From 3 to 7 in the mandible. You don't need attachment of 4 incisors. And if it interferes with the occlusion, then you can choose a lingual side, especially in the lower arch. That's what I do. And we need to create the space for the lower incisor. We need to distalize gradually. This is the latest picture. We're almost there. But let's have a look at the way how we develop the arch. What did I say? It has a weakness in transverse correction. But as you see, we expanded the lower premolar width from 39 to 45 in just about 6-7 months of time. But we are not going to say this is a skeletal expander or something. This is a transverse decompensation. Just because the lower premolars were inclined to the lingual side, we had to upright the lower premolar. But the expansion effect was very striking. Simply because the number is a 60 millimeter increase from the beginning to the middle of the treatment. We are almost at the end of the treatment. But what did I say? It has weakness in transverse correction. But in this case, it expanded the arch. What did I say? It has a strength. What is that? What did I say? It is, in nature, reborn arch that has a horseshoe shape. Just like the Damon arch wire. Just like the Damon arch wire, it will have a strength in the transverse correction, but only in the premolar area, not in the first molar area. You understand? That's exactly why the previous case did not show a very striking outcome. In the second case here, it looks like very well developed lower arch. This is a 6 millimeter increase. And this is the intraoral view taken with the aligner inside. And what am I going to show you in this figure? This is very nice. So, what are you worried about? Every time you give the new aligner sets, what are you worried about? What is the nature of the aligner? First, it is a shape-driven appliance. Second, it has an increment of only 0.2 millimeter from number 1 to number 2. Okay? Only 0.2 millimeter. You are able to move the tooth from between number 1 and number 2. That increment is only 0.2 millimeter. Okay? If let's say you have a aligner set number 8, and you are just about to move on to aligner number 9. Okay? And then you have to make sure if the fitting is really, really perfect. How perfect does it have to be? How perfect does it have to be? You have to be able to detect like 0.1 millimeter discrepancy between your teeth and your aligner. My question is, are you able to detect, or are you able to make sure that, for example, number 8 aligner is in perfect fit just now? Yes or no? How do you make sure of that? How do you make sure of that? You really have to have a look at each of the tooth. And you have to go in. You have to really go in between the aligner and tooth by yourself. You shrink down your body and go in to figure out or otherwise you can take a micro CT scan. Oh no, that's not possible. If, for example, if there's once again, let me tell you, there's millions of articles published so far. They always keep talking about shape memory, direct-to-printed aligner, what is that? Stress relaxation that I don't know. What is the stress relaxation, by the way? They keep talking about all these unknown terminology. What matters from a clinical standpoint, when you have a liner inserted in the patient's mouth, that you have to make sure there's a perfect fit, central incisor lateral from 1 to 7. You really have to make sure that your aligner is in perfect fitness in an entire tooth for you to be able to move on to the next aligner, which is from 8 to number 9. For example, if the aligner is a little bit wobbly in the back side of the arch, like second molar area, you're not sure whether you can move on to next. Now, if something like that happens, and if you're using number 8 aligner, from number 9 to number 56, they all have to throw away. You know what I mean? You know what I mean? If it doesn't fit, let's say you have a 65 aligner sets, and if you have a little bit leakage or a little bit deformation at aligner number 9, you cannot possibly move on to the next. The rest of things we have to go to this trash bin. Do you understand? That's the reality too. The problem is, at this status, you have to make sure. Have a look at the 5. Do you see anything? Have a look at 6. Do you see anything? Are you sure the aligner is in perfect fit with a lower 6 or upper 3, for example? How do you think you can make sure? If you simply move on to the next aligner set without knowing what's going on, then you will end up with a lot of tipping. And then aligner sets, if number 8 doesn't fit perfectly, number 9 definitely will not fit. Number 10 will definitely not fit. Does it make sense? So what is the point? Every step of the aligner, we have to make sure your aligner, whether it's number 8, number 9, number 10, we have to make sure they are in perfect fit in every step of the treatment. With this and that type of attachment, with this and that type. Have a look at this one more time. How can you make sure the aligner around the second premolar is in perfect fit? How do you make sure? Let me suggest one thing. Have a careful look at attachment. Have a careful look at the attachment. What does it look like? It is a teardrop. If it has a perfect fit, then it will have a shiny spot at some part over here. Okay, it's in direct contact. It's in direct contact. If it has a little bit of distance, you can notice some air bubble or void in that area. So you can easily make sure your aligner set, whether it's number 8 or number 9, is in perfect fit. Without this kind of apparatus, not easy for you to detect what's really going on. So we were able to develop the arch, like I told you, basically just because it has a horseshoe shape. It has a weakness in the transverse correction, but only in the back side of the arch, which is first molar and second molar area. So again, let me tell you, it has a strength in the transverse correction. If you think about the morphology of the aligner, it has strength in the arch width correction in the premolar area. And it's not only me who keeps talking about this.